Hello, everyone, and welcome to this presentation today. It's going to be very interesting, and I look forward to the discussions. So I'm Professor Eftihia Vardas. I'm Head of Clinical Virology at Lancet Laboratories, and here is my conflict of interest declaration. Not employed by Roche, and I'm not receiving an honorarium from Roche for this presentation. So let's start of where we are in South Africa now with COVID-19. We're a year in from the first few cases and almost a year to the anniversary of the first hard lockdown of level 5 in South Africa. And without a doubt, this virus has changed us in every single way, professionally, personally, and economically. So these are the latest statistics from the WHO as of the 12th of March 2021, and we have had 1.5 million cases in South Africa confirmed, 51,000 deaths. And there is some good news. 145 plus vaccine doses have already been delivered. What is very clear on the slide as well is the two waves that we've had in South Africa. And we're hoping that we will prevent the third wave. But here we have the two waves that occurred, the first set of infections, and then at the end of last year, the second set of infections. So here's the virus that changed our lives. It is an enveloped virus, RNA virus of 120 nanometers in diameter. It has these petal-like spike proteins that are stick out of the surface of the virus. And this petal-like spike protein is about 20 nanometers in diameter. And its function really is to attach itself to the ACE2 inhibitors on human cells and cells of other animals that this virus infects. The other structural proteins of this virus, we have the envelope protein, which is also important, membrane protein, and then the nucleocapsid protein, which is actually the most abundant protein made by this virus once it starts replicating inside the human cell. In the second panel of this slide, we have the genome sort of stretched out of the virus, and we can see that the genome has the structural proteins and then these non-structural proteins, the open reading frame non-structural proteins. And a lot of the PCR diagnostic tests include some structural and non-structural proteins, combinations of them, or some only just structural proteins. But there are combinations generally of these genes within the PCR tests. What the bottom panel shows is that very quickly we realized once you got infected with this virus, the symptoms that were developed from this virus. And you can see from them fever, fatigue, loss of smell, dry cough, anorexia, etc. These were quite non-specific symptoms. And actually at the beginning, we used these almost solely as a case definition of whether or not you have the virus. And very soon, much later on, after first identifying this virus, that we had very highly specific PCR testing that could give us an indication of whether or not you were infected with this virus. The other things that we learned quickly was that we know that there are a total of 6 known human coronaviruses. The top 4 here that we have listed, those are the respiratory coronaviruses. And then we have the big ones that occurred. These are also recent jumps from animals into human beings. The SARS-CoV in 2002, 2003 from a civet was first identified in China. And then, of course, we have MERS-CoV in 2012, which is the Middle Eastern coronavirus, which had an intermediate host from a camel. The current coronavirus we know comes from a bat virus originally. The intermediate host is a pangolin, and we know that close contact between humans and whatever the intermediate host or the primary host has caused this virus to jump into human beings. As with all new zoonotic infections, our immune systems are completely paralyzed because they have never met this before and have to adapt quickly to fight off this infection, and hence the virulence of this virus is quite high. We also now know on this other side of the coin is that humans can pass on this infection to other animals as well. And we've seen passing on of the infection to cats, dogs, domestic animals, as well as to farmed mink animals. This graph shows the case fatality and something called the R0, and you're all very familiar with this, but I'll quickly sort of run through it again. The case fatality rate is the number of deaths that occur divided by the total number of infections. With SARS-CoV-2 or COVID-19, we never really have had a handle on the total number of infections, and so the case fatality rates have been a little bit skewed and difficult to work out. If you look at this red dot, this is the novel coronavirus. This is the row for novel coronavirus. It's between 2 to 3. What does that mean? It means that one infected person can transmit this to 2 or 3 other individuals. Compare this a little bit with chickenpox and smallpox. 5 other individuals will be infected by one. And look at HIV. 6 other individuals will be infected by one infected individual. So this gives you a bit of a perspective of how it all fits in. We also had some good news, I guess, early up in the infection with the novel coronavirus, and we started to realize that the vast majority of cases were going to be mild, and 81% of cases were mild. We had some severe cases, but this was a low percentage, about 14%, and 5% of cases were critical cases, of which 2.3% died. What was an unknown and a sort of an iceberg waiting for us was that we discovered that there were certain asymptomatic cases. And so this was our Achilles heel to any control strategy, because we realized that some individuals did not show any symptoms and yet were infected with the coronavirus. And this became obvious, and lots of publications occurred over time and quite quickly. And then there were the 2 sort of natural experiments of the cruise ship, the Diamond Princess, and the US aircraft carrier, the Theodore Roosevelt, in which these are confined spaces where we saw that people got infected very quickly from asymptomatic individuals. And we saw in the Diamond Princess where people were older and had more premorbidities, that they got sicker. Another surprise was this asymptomatic infections in women admitted for delivery in New York. And in fact, this was quite a high percentage. And this was diagnosed using serological assays. 13% of women admitted to deliveries had asymptomatic infections because they were detected by having antibody tests. So how did we manage this pandemic? Luckily, we had a pandemic plan. And this pandemic plan is a plan that had been put together to manage an influenza infection that was going to come to us. And most of this pandemic plan was really split up into various strategies. And these strategies here are listed as sort of continuums, but in fact, they're not. And most countries skip between different strategies. Let's start at the bottom. No substantive strategy at all. And a lot of countries of low income had no strategy, and they were just allowing infections to occur without any control. In fact, Sweden started off it was a mitigation strategy, but then moved on to no intervention at all, allowing people to get naturally infected with the idea that you would build up a group of naturally infected individuals, and eventually natural transmission would die out. Obviously, that is not what we wanted to do in most other countries. And most countries went from mitigation to suppression strategies. Mitigation strategies were really trying to suppress the curve so that we wouldn't have an overwhelming of healthcare facilities. And then once we got over those peaks, suppression strategies to try and prevent transmission. And we were all surprised at how effective these non-pharmaceutical interventions were. The wearing of masks, hand sanitizers, social distancing, the stopping of having large groups of people congregating together for whatever reason. The aspirational ones are the ones at the top of this diagram, the exclusion and elimination strategies. And we will talk about this a little bit later, but these are the strategies of us trying to get back to normal. And the only way we can do that is if we have some help from vaccines. And that's the only consideration at this point in time, and the hope of most of us. This graph here is a graph from New Zealand, which actually shows, and New Zealand, one could argue, is an island, and it was easy for them to control the introduction of new infections by closing their borders and by having very strict testing and quarantine criteria. And so, in fact, if you look at just this green panel here, a large part of the success of New Zealand has been because of their testing situation. They had very quick testing, available testing all over, and good quarantine after testing. This was also shown in Korea and in a lot of other Eastern countries, as well as in China and in Singapore, etc. So testing became the crux of this whole strategy to control this infection. This slide here simplifies this whole idea and simplifies this pandemic plan that we had by looking at just the testing strategies. And this is a document that was put out quite early in the South African epidemic in May of 2020 by the Colleges of Medicine of South Africa. And they said, okay, so what are our testing strategies and what do we want them for? And so the first thing is, well, we need testing strategies for screening. And that is to identify individuals who may have SARS-CoV-2. We started off, as I said earlier, with a symptom questionnaire, but then we moved, once we had capacity, to being able to do that using PCR testing, using nasopharyngeal samples. PCR testing itself is really designed as a diagnostic tool, and it was really not made as a surveillance tool. So it became a test that we started to put into a position that it never was really made for, but it has performed very, very well. And then you look at the last part of the strategies for in the pandemic control is surveillance. And surveillance is important so that we can determine the proportion of individuals that have been infected with COVID, either most recent within the last 14 days or in the past. And that is done on blood tests with serology, IgG, and IgM testing. If we just look at this graph here, and this is South Africa's PCR testing and what has been done. The light blue is public testing and the dark blue is private testing. And then you have a line that shows the average number of tests. Just look at the remarkable achievement that we have had. We've got over 9 million tests have been done during our COVID pandemic so far, looking from May until more recently in March. And you can see that we have ramped up our capacity in private and in public sector, and we have been able to do this. And yet, these tests are not the only tests available for management of a pandemic, and people need to present themselves for testing. And certainly at the very beginning of the epidemic in South Africa, we struggled to keep up with the demand for testing. And asymptomatic testing, we could not provide tests for that. And we had to reserve our testing for the diagnosis of people that were ill with infection. And so although this is a very nice graph and it seems to show you the two peaks, it doesn't really tell you how much COVID-19 we had in South Africa. This paper by Jaap Goudsmit actually really also very early in the pandemic, and you can see here the date that it was on the 9th of April, put out this paper saying you really need to do serological surveys so that you can know how many people have been infected, what are the transmission chains and the transmission dynamics of this infection. And we really didn't heed this warning. And he was saying that it's necessary for us to understand this so that we can stop separate waves of the pandemic occurring. So we never heard the advice of this author, and we've been hit with a very big second wave. And hopefully we will heed the advice and be able to control it a little bit better with a third wave that is imminent. So let's examine the reasons why we want serological testing. Well, here I've really listed the immunity reasons, not the clinical reasons. So we look at the immunity. We want to know who's been had a natural infection previously. We also want to use serology to tell us about their response to vaccines. Have they responded to vaccine? How much they've responded to vaccine? We want to look at the population immunity or the community-based immunity to understand who has been infected and are we reaching the so-called magical herd immunity. We also want to target high-risk populations, healthcare workers, people in congregate settings, that's people in frail care, as well as in prisons, where because of confined spaces, the infection can move quickly through these communities, and certainly in frail care, where people have high risk and are elderly, results in high mortality. Going back to this issue of estimates of who's been successfully vaccinated, this is becoming a pressing issue. Even now, after 145,000 vaccines being given in South Africa already, people are phoning up and asking us, can we please tell them, has the vaccine worked and what can they do about that? The other side of this coin are the clinical uses of SARS-CoV-2 serology, and we know that they can be used to track recent infections in asymptomatically infected with high-risk groups, for example, emergency workers and healthcare workers. And you can use them more frequently and do testing more frequently because they are cheaper and more accessible. they can be used as an adjunct to PCR testing. We know that PCR testing, because of its very nature, can cause false negative or false positive results. False negative results being a much higher probability and dependent on a lot of pre-analytical issues regarding the sample taking, how the sample was stored, how the sample was taken to the lab, etc., and can be as high as 60%. False positive PCR results, these are patients with very high CT values that are asymptomatically infected. And with or without a serology result, you can actually make a call whether or not that was a real infection or was that just an artifact of the PCR testing. We can also use serology to estimate time from infection and as an adjunct, in addition to PCR testing. We really are not advocating that serology would overtake PCR testing in the acute infections. They are important in multi-system inflammatory syndromes in both children and more recently the publications that have shown us that this syndrome can occur in adults. This is a syndrome that occurs after COVID infection where you can't detect this virus anymore using PCR testing, and your only way of knowing that there is any connection to the virus is using a serological test. And then finally, the identification of plasma donors. There's a lot in the press about using high titer plasma to treat certain COVID infections, but of course that also is not being used very much. So what are the types of SARS-CoV-2 immunoassays? There are different types of tests and people get confused about these. And so that's why I've spent some time to try and clarify it. There are antigen tests, which are done on respiratory samples. And these, we will show you on a graph just now, are really very good in the symptomatic individual. They have very good sensitivity and can identify individuals that are infected with that infection that are symptomatic. Antibody tests, there's a whole array of the antibody tests, IgGs, IgMs, and IgAs, and people are confused about them. There are two main groups, either laboratory-based tests that are done on high-throughput platforms, either ELISAs or chemiluminescent assays, or lateral flow point-of-care tests. And a lot of the fear and anxiety about immunoassays has developed because of these lateral flow point-of-care tests. But let's unpack that a little bit. The design of these immunoassays, there was a lot of debate at the beginning of which antigen do you use in these immunoassays. And in fact, there are two really good sets of immunoassays. Those that are made with spike protein, which is very immunogenic. And we know that it actually is what is now in the vaccines as well. And those that are made to the nuclear protein, which is the most abundant protein. And those that are made with combinations of both the spike and the nuclear protein together. Whether or not they detect IgM or IgG or combinations of both as well is the other confusing thing. But we are learning swiftly to try and classify how we use these assays. You're not meant to look at the detail of these slides, but these slides are really meant to show you part of the fear with these immunoassays. And part of it was because of this misunderstanding that immunoassays were all clumped together, whether there were lateral flow assays that were done as a point of care or high throughput assays. So the graph here on the left shows sensitivities of these assays. And you can see from the scatter of the sensitivities that some of these assays are very good at detecting the actual condition or infection, and in this case, COVID, and some of them are actually very bad. So the more they are on the left-hand side, the worse they are, and on the right-hand side, the better they are. They're very specific. So if you look at their specificities, you can see that almost all of them are actually able to exclude infection in an infected individual. So a negative antibody test is very specific in excluding the infection in that individual. So the philosopher Nassim Taleb has put out this theory about Wittgenstein's ruler. And what does that mean? It actually is a duality, is that if your measuring instrument is measured by what it tries to measure. And this is what has happened and why we had this whole misunderstanding about sensitivities of serological assays compared to PCR. So PCR is a flawed ruler. And we were still comparing both lateral flow assays, as well as high throughput assays to the flawed ruler of PCR, and sometimes not even doing that at all. And we were really missing the boat. So we were the two things that we were unable to use this flawed ruler to give us an indication of what it was our community prevalence, as well as our infection fatality rate, as we've already said, our case fatality rate. So this is a generalized curve of laboratory testing for infectious diseases, and we have this little gray box here that says before symptoms and what testing is used and can be used before symptoms. And you'll see this blue line. If you follow this line, it is viral RNA, and viral RNA does become positive before symptoms appear. So it always has an advantage. This dotted green line that follows that is antigen testing as well, which can also be used before symptoms appear. But really, as you can see, its peak usefulness is once symptoms is there. What is the window period? We're very used to window periods from HIV diagnostic serology. It's from the time of onset of symptoms to the detection of antibodies. And with SARS-CoV-2, we were a little bit surprised to realize that both IgM and IgG were occurring at the same time. Usually there is a sequential appearance of these antibodies, but with COVID, we saw that they were appearing at the same time. A lot of people said this was too complicated and people couldn't understand serological testing for COVID. But in fact, this graph here that I've superimposed is serological testing and PCR testing for HIV. And we've become quite adept at understanding both serological and PCR testing for HIV over time. And I think we will become more adept with COVID as well. So how did we start using these COVID tests? Well, in fact, they started to be used all over the place. And most people were using high throughput serological tests that were done in labs. And in some instances, they were doing point of care testing. Iceland, another island, did a whole population screening using 6 different serological assays. And they showed that 91% of those that had recovered from COVID infection showed antibodies as detected on these PCR tests, and they kept those antibodies for at least 4 months after PCR infections. A lot of infections occurred in patients that had 14%, which is quite high, that were already in quarantine and that had not got PCR testing at all. In a study that was done in New York, in a large sample of 70,000 individuals, these were healthcare workers, and they had an overall prevalence of infection of about 13.7%. And it was highest, not surprisingly, in staff that were working in ICUs or in emergency rooms. This study from Washington showed that a long-term care facility or people in old age homes, 82% of residents actually had antibodies to SARS-CoV-2 or to COVID. And the most interesting thing was that 30% were asymptomatic. We've done a similar study in South Africa where we've shown up to 50% of residents in an old age home became infected with COVID, but were asymptomatically infected. This other study in Belgium, also done in 4,000 individuals, healthcare workers, and with an overall seroprevalence of 6.4%. But these were done early in the epidemic. Other uses of these assays, these serological assays, have been published now towards the end of last year. Lots of studies came out. And here, this is a systematic review of 47 different studies, which has shown us a map of pooled prevalence of the globe. And the systematic review has an N really of about 400,000 individuals and a pooled estimate of 3.3% prevalence of individuals that are infected or exposed to COVID. They compared different countries, and there is a gradient of individuals that were infected, at least from the published studies, from South America at 1.4% to Northern Europe at 5.27%. The other big study that came out in January this year was the Indian national seroprevalence in 38,000 individuals, which did, if you just look at the red line, it shows the seroprevalence measurements that were shown here, and as high as 45%. That was the observed prevalence. And this was using a high throughput ELISA that was done on individuals various age groups and in various clusters in different regions of India. And it showed that the seroprevalence in children between the ages of 10 to 17 was 5.4%, and this was the lowest, and it was highest in adults between the ages of 18 to 44. It was higher in urban slums, and certainly you'll see this being reflected in South African data as well. This data, really just looking at the colors of the graph, blue being no antibodies detected, red being high antibodies detected, and orange and yellow in between antibodies detected. These are different time points in the US, starting in April and ending in September of last year. And you can see that there is coloring in of the different states of America, showing the prevalence of SARS-CoV-2 antibodies in those populations. In South Africa, what do we have? We have very limited data in specific populations. We have this study that came out of the UCT group that showed a 40% prevalence of infection in antenatal clinic attendees, as well as people living with AIDS. And they used residual samples from these individuals that were tested for other things, and they tested them again on high throughput ELISAs and got this very surprising value of 40%. Another study that has been published in a preprint in January of this year from the blood donors, looking at blood donors in different provinces in South Africa, really also showed quite high prevalences, as high as 30%. In KZN, much higher, up to about 45%. And just look at these little dots up here. These are, they've done an analysis based on race, which is quite old-fashioned and certainly difficult to justify, but they have done racial classification, and it shows a higher prevalence in Black and Asian individuals. Our own work based on the laboratory prevalence, and obviously this is skewed and it cannot be extrapolated to the general population. We've done about 27,000 odd antibody tests, and these are IgG to the nucleocapsid on a high throughput ELISA, and our seroprevalence is about 30%, with a range of between 8 to 48%. And you can see that it seems to go through peaks and troughs. But again, this is a laboratory-based cohort. It's people requesting antibody testing. Very much in the beginning, you couldn't get an antibody test unless you had a doctor's referral. That has more or less fallen away, and people can get it on demand at this point in time. But it is an interesting statistic of about 30% prevalence. It does get even more complicated because we know from those 4 human coronaviruses that do cause mild upper respiratory tract infections that we get reinfections. We also know that mild disease causes quick waning of antibodies. And we also know from the 2 more serious human coronaviruses, the MERS and the SARS-CoV-1, I suppose, that we can have persistent antibody responses for up to 2 years. So there's like a mixed message there. What we don't know with COVID-19 is what is a correlate of protection and what is a standard, a quantitation. How can we quantitate it? And certainly NIBS has put out standards for spike protein IgG antibody assays, but they are complicated and they are not as easy to extrapolate to a clinical situation, for example, in post-vaccination, as we have already for other infectious diseases like hepatitis B and measles and varicella. The other thing that's made it complicated is that there's been a lot of information out there about the so-called reinfections. Some of them are not reinfections and are really just because of the vagaries of the different diagnostic tests, but some of them have been documented as real reinfections, and so we have realized that reinfections occur. The other spoke in the wheel has been this variant situation, and here we have a graph showing the differences of the British or UK variant and the so-called South African variant. This graph here from NICD, this set of pie charts, are really there just to illustrate that from August, right at the very top left-hand side to the bottom right-hand side, we've gone from one variant to a complete replacement to a completely different variant. And that's been the change that we have seen. So currently circulating in South Africa, we have only the new variant circulating. So, but there is good news, and there's a silver lining here. We know that we have a persistence of antibodies for more than 6 months in even mild to moderate disease, because people have always said, well, it's only the very sick people that develop antibodies, and the mild to moderate people don't get antibodies. In this paper that was done in a big study in 6 different centers in Germany, they've looked at IgG, IgA, and IgM antibodies. The dark is high levels and the light is low levels, and they've looked at various time points from 14 days after infection to 30 weeks after infection, and there is still an IgG response. The IgM response, as we would expect with any infectious disease, does eventually fall away. But the as does the IgA response, but the IgG response is important. And the test that they used in this study was nucleocapsid IgG. Other big studies have also come through. The Belgian study that has followed a cohort of 850 healthcare workers for 7 rounds of testing. And they've used spike protein IgGs as well as PCR testing. And their median follow-up is at 170 days. And they've showed 91% of them are seropositive, 82% of them have got neutralizing antibodies. And so this is the good news, that there is a long-lasting response. Not only that, and this is an early Christmas present from Lumley et al. From New England Journal of Medicine on the 23rd of December, they showed that the presence of antibodies actually protected healthcare workers to the risk of subsequent infection. And so that makes it really good. So if you look at healthcare workers that don't have antibodies in the red, and the incidence of infections, they get infected. Healthcare workers with antibodies, and these are spike protein directed antibodies in the blue, don't get incident infections or new infections. The big thing is herd immunity, and this is what we are really after. And the only way we can do this is putting the genie back in the bottle, of the COVID genie back in the bottle, is using COVID vaccines. And there is a multitude. We are spoiled for choice, lots of vaccines and very good vaccines that work very well. With the coronavirus vaccine rollout plan in South Africa, we have these phased rollout plans. We are currently in phase 1, and we need to get very quickly to the other phases of the vaccines, but there has been a lot of back and forth about which vaccines we need. But we really, really do need those vaccines, because the only way we can get to an elimination strategy is once we have vaccines. Unfortunately, the current headlines are showing us that we will miss our target for vaccinations in South Africa. However, we are still hopeful that we will have more vaccines and quicker rollouts or more efficient rollouts. The last point that I want to make is that we can eliminate this virus. Elimination, as we all know, is stopping the transmission or the natural transmission of the viruses. We've managed to do this with various other viral infections like measles and polio. We've eliminated it in various parts of the world. Eradication, I'm not sure we were ever going to make it. Eradication is actually just eliminating it off the face of the earth. And we've only done that once for human diseases with smallpox. So how can we stop COVID-19? There are many, many, many plans out there for elimination strategies. And really, what are the elements of those elimination strategies? We need to be able to show an absence of new infections within a particular region over a period of time, and 28 days has been bandied around as being that period of time. We need high-performing surveillance systems that need serological assays, and we need to be able to target geographic and population regions to measure seroprevalence in those populations. We need the acceptance of suitable exemptions. So, for example, New Zealand said that they have eliminated COVID, but they really hadn't. And in fact, you get introductions into the country of new infections from travelers. So you need to be able to control borders and to be able to do testing efficiently at borders to control that. And once you've identified an infection, to be able to isolate and to quarantine effectively. Well, thank you very much for all of your attention and for listening into this presentation today. I hope it has been of some use to you, and to try and contextualize how we can control COVID-19 And there is a silver lining with vaccines. Thank you.